Yeah, so to start things off, I would like to be interested in what inspired you to pursue medicine in the first place. It's a huge field, and there's a lot of like complications, and it's a tough field to get into, especially because it's so long.
Mhm.
So what inspired you?
The science.
Yeah.
I mean, it was always a strong subject for me, the science, and just I like people, and I
Mhm.
like trying to help people. When I interviewed for medical school, the physician who interviewed me at the very end of it says, everything you talk about, why don't you just become a preacher? With the idea of helping people and
Mhm.
doing things with people. And I stopped, and basically the answer is because I like the science
Yeah.
and the challenge of the science that medicine provides, in addition to everything else.
Your background as there's little routes that you could take in a way to approach your career.
Mhm.
Some people are saying preacher because you wanted to help so much, but the science part.
Mhm.
So, in respect to that, did you know you wanted to become a doctor, or what were you interested in first before knowing you wanted to become a doctor?
I was expecting that I would probably be a professor, like in zoology, in one of the sciences
Yeah.
or one of the life sciences. And quite frankly, I was in a class with a bunch of upperclassmen, and it was during the spring when a lot of them got their acceptances to medical school. And I just kind of looked around the room and realized that, I was as good a student as they were.
Mhm.
And just talking with them, we had a lot of similar interests. And I said, I'm just going to apply and see what happens. And sure enough, I got in.
Oh, that's
Doesn't sound like a real motivation to be a
Yeah.
doctor, but that's just how it happened.
That's-
I said, if they can do it, why can't I? Let me try and just
Yeah.
see. And that's when it kind of solidified that I actually intended to be a doctor.
and it worked out really well.
Yeah, it did.
look
Yeah.
at-
The rest
look
is
at you.
history.
Yeah,
The rest is history.
Yeah. So we were talking about what made you change your mind,
Mhm.
and from professor, it's just the enlightenment of science, right? Such an interesting topic, and it's growing now that
Mhm.
space and also advances in biology are also happening. So it's a really great
Yeah.
time era to be.
The pace of knowledge is extraordinary, not just the availability of it, but there was a time where it was estimated that half of what a doctor knows is obsolete in 2 years. I think we're moving to the point where that's even faster than
Yeah.
that. It's
Yeah.
just moving so quickly.
Yeah. Speaking of this time era, how did it change between when you were a doctor back then in your
Back
in early
then,
in the early years of your
okay,
career?
a while ago.
In the early years of your career, how different was medicine compared to what it is now in the 2020s?
It's become a lot more technical and a lot more test results oriented than it
Mhm.
was initially. And then just the availability of all the options for care. Like when I was an intern at Parkland, in order to get a CAT scan of the head
Mhm.
for a stroke patient, because there was only one new CAT scan machine that was basically almost experimental, you had to get a neurology consult.
Oh wow.
Now
So
I
that's-
can order a CAT scan anytime I want. And the same thing with like dialysis. Dialysis was just becoming a common treatment when I was an intern. So if you had a patient who needed dialysis, they literally had to be hospitalized and seen by a nephrologist and then looked at by a committee before they would be approved for dialysis.
So it was harder. It included more steps to get care back then than it does now.
For the new things that were coming out,
Yeah.
but the pace of development and the new techniques and everything that have come out is so rapid. They pretty much are adopted
Yeah.
immediately,
Yeah.
and they're available immediately. Especially in this area, this area is so competitive,
Mhm.
healthcare wise, that if one hospital gets a machine equipment or something, the other ones are going to follow suit,
Yeah.
so that things appear pretty much instantaneously here.
Yeah. That's great. That's awesome. Also, we was looking into if memorable experiences, especially that solidified your way not only to becoming a doctor, interest in science, but why specifically pulmonology? That's a big step in one career of medicine versus all the
Yeah.
other.
When I finished medical school, I actually was thinking I would be an oncologist.
That's what I want to be.
And part of that was I got accepted by the National Cancer Institute for a 3-month rotation there to do my clerkship.
Mm-hmm.
And actually, interestingly, my resident was Tony Fauci.
Really?
Yes.
And just to jog my memory, I've heard of that name before.
Yeah,
but
he's
who
Anthony
exactly?
Fauci for the COVID. He was the director of the NIH.
Oh.
Yeah,
Oh,
so
yeah.
he was my resident at the Cancer Institute when I was there for my oncology clerkship. The I changed during my internship. It's a real personal thing, but the first rotation I had on the wards at Parkland, had a patient who was basically my age, who was leukemic, an acute myelogenous leukemia, which at that time the chemotherapy was extremely toxic
Yeah.
and very aggressive, and just a really nice kid. The nurses just loved him. And he was basically, his mom was a single mom.
Mm-hmm.
So he was basically by himself in the hospital.
Yeah.
And he was everybody's favorite patient. So I was helping him as he got into the initial part of his chemotherapy. And then I rotated off service to another service because it was month by month.
Mm-hmm.
And I came back on the wards again. I went to the ER and then came back on the wards again after a month, and he was still there. And his health had gone down dramatically. I mean, the treatment was so toxic, he was nearly deaf. He was in renal failure. He ended up dying on my second rotation on the wards.
Oh, wow.
And then when I went from there back to another rotation in OB, the first week we had a young woman who delivered a child, but she had what's called a hydatiform mole. Basically, her placenta became malignant,
Mm-hmm.
and it's a wildly aggressive cancer. So this young woman had a baby and basically died of cancer a week later. After those two things, I just said, I'm not doing this for my lifetime. I'm just really not, emotionally or psychologically ready to do this all the time in my lifetime. And the sequence of events, a couple months later, I was on the pulmonary service. And the thing that caught my attention, or the appeal of pulmonary, is that you have patients who literally can be almost dying of like pneumonia,
Yeah.
literally almost dying, but with good treatment, they recover, and you might see them in the hall 3 or 6 months later, they're completely normal again. So it was really an appeal to me that you could have an enormous impact on people, and they actually recovered and went back to a normal life. Very rewarding. I mean, it's all rewarding, but a lot of the specialties in internal medicine are managing chronic disease. In pulmonary, we manage chronic disease, absolutely, but there are a lot of times where we truly make a difference in someone and can save their lives. Very gratifying. So that was kind of the appeal, the acuity, the sickness, of taking care of really critically ill people, in addition to managing chronic disease, is what made it for me.
Yeah, those are two very powerful stories, I would imagine.
Well, and I had really good, some of the professors at Southwestern that I really liked turned out to be pulmonologists.
Yeah.
I don't know if it was because I was interested in it or just how it happened, but some of my mentors were the pulmonary service.
Yeah,
at
so
Southwestern.
stuff around you influences
Absolutely.
great
Absolutely.
outcomes. And that's actually really wonderful how you shared those two stories. They were very interesting, very emotional. I get how being a doctor has a very harsh emotional emotional target on you. You have to be able to deal with these situations. Otherwise, it'll be really hard to switch. And that's why some fields require different skills than others, and that reflects on the most necessary skills to become a not just a doctor but a great doctor? Because for those med students out there, they're wondering how do they want to improve themselves, not externally but internally as a person.
The only thing I would say is, I mean, you always do the very best that you can, so that if you have a patient who has a bad outcome, you know you did the best that you could. You did everything you could to help them, and it's so that you're comfortable with the fact that you were their physician, and it just wasn't meant to be.
Yeah.
And then just resilience. With access to information from the internet, it's really no longer as important to be able to list the 12 causes of anemia when you can go look them up. So the immediacy of it, has made it a lot more complete for people, but you never want to lose the interaction with patients and the contact with people.
Yeah.
I mean, you can be the smartest person in the room, but if you don't relate to your patients, or you don't care about caring for your patients, you're not going to be a good doctor. So you need to develop that, and you just need to be resilient. I can tell you, I'd rather have a doctor who was resilient and persistent than one who was the brightest kid in the class.
Yeah.
Because with medicine today, prior authorizations, a lot of the stuff that's going on, you really, really have to stick with it to get things accomplished.
Yeah.
You just can't give up your hand, throw up your hands and give up. And a lot of what you have to do that you need to be persistent about, the answer doesn't come off the internet.
Yeah, I totally agree. That if you're the patient, if you step in the patient's shoes, who do you want your doctor to be? And that's how doctors should think about how.
Absolutely. Well, I can tell you, the first day at Parkland as an intern, they brought us all into the room together, and Dr. Selden, the chairman of medicine, basically sat us down and he taught us a lesson for our service at Parkland that I've held to all along, and I think everybody should hold to, is that basically the point he made to us is, look, people, the patients you see here aren't here because they choose to be here. And most patients don't choose to get sick, but at Parkland, they have no options. He says they're your patients because they have no choice, they have no options. That doesn't change anything. We want you to treat these people, these patients, like they're your family or your parents.
Yeah.
And that was the philosophy of care there. And it's served me well since, is that every patient is to be treated like a brother, sister, aunt, uncle, or a parent.
Yeah. And touching up on resilience is a big factor to becoming a doctor and what skills you should develop. During those key study periods, or like the journey to becoming a doctor in med school, what kept you motivated during study nights or long shifts that just it pushed you to not give up in terms of resilience?
Well, several members of my internship class did give up.
Yeah.
And frankly, no discredit to them if they weren't cut out to be the doctor that Parkland was expecting. I'm glad they found another option to go on and still be a productive doctor. Again, just the most important thing at Parkland was it was just such a high pace and just so constant. Quite frankly, you just got swept into the flow, and it was hard to even think about not keeping up because the next patient was a phone call away. So I think for a lot of us, we just were swept along by the pace of the training and never paused long enough to wonder if we were doing the right thing or needed to keep going at the pace. It's Southwestern's pretty competitive.
Yeah.
I mean, it was a group of double type A physicians, but I'll tell you, the first couple days as an intern, you're looking around and you're seeing interns that are from Harvard, Johns Hopkins, from other schools, and you're going, whoa, you know,
It's up there.
wow. But after 2 or 3 days of being on call, you realize it was a great leveler. Everybody was in the same boat. Everybody was scrambling to keep up because of the pace and just the daunting task of accomplishing the knowledge and the work physically. So that, you know, after a week or two, it didn't matter where you went to school. We were all in it together. We were all aiming at the same thing, which is trying to be a good doctor.
Yeah, and so that's why I've heard a bunch of information about it doesn't really matter what school you go to in terms of becoming a doctor, because it's not the schooling that's the most important. It's the character development, and it's the, I'd say, just the level of yourself not compared to everyone around you, as you would get if you're an engineer at different schools, but just the level that you can upgrade yourself in terms of being a good person as a doctor.
There's no question about
Yeah.
that. Is that, and even if it were still important while you were in training, you know, whether or not you were third in your class at Hopkins, or you know, fifth in your class at Duke, even if it was important in your training, when you get into private practice, it doesn't matter.
Yeah.
Patients come to you seeking help, and if you establish a relationship with them that they trust that you're going to help them, doesn't matter where you trained, it doesn't matter where you went to school.
Yeah, totally.
It just happens. You just need to be well trained in order to do the right thing.
Yeah. So earlier in this interview, we were talking about how you face many chronically ill patients, those who are way past their prime years and probably nearing or succumbing to their illness, right? And as a pulmonologist, as a doctor, and through this era, there's a bunch of information spreading all throughout the internet. I mean, just views on how doctors are relating to mortality with patients, on how to approach them, and how treatment is different from patients that are, no matter what you really do, they're gonna eventually pass away, or versus different patients that are just your cure and go, right? But that's not how you should view patients. The cure patients would sometimes lead to more suffering in some cases, where your ethics on mortality, and how would you approach a patient that's nearing death if a cure would actually help them, versus how you should focus on the emotional treatment and how they should pass away in a less suffering way.
The most important thing is that patients need to know that you care,
Yeah.
and that you care about them and what's going on or with them. So you develop that level of trust, and then when you have that level of trust, it's just absolute honesty. Even if what you're going to say may be painful or difficult for the patient to hear, they need to hear it.
Yeah.
So that if they trust you and know that you care about them, even bad news is something that they will adjust and tolerate to, just simply because of the person you are when you deliver it.
Yeah. So it's a great deal. I've actually read many books and watched many documentaries about how different doctors approach those who are nearing the end of their lives. And how would you reflect on like technical treatment where you focus on the cure? How would you say the most important style is? Basically emotional treatment, which is what we just talked about, or a technical treatment where curing is the sole option? Because many doctors are very often deciding whether to focus their emotional support versus technical cure. And so what I've seen from the doctors that I've shadowed, it's really important to decide, but also to integrate both aspects, right?
Oh, it has to be integrated.
Yeah.
But I mean, it's patient autonomy.
Yeah.
At the bottom line, even if you have a technical cure for a patient, the patient needs to understand what you intend to do, and they have to agree to it.
Yeah.
They have to want to do it.
Yeah.
You can't just force them to do things, even if it may be a
Better,
cure for
or-
them,
Yeah.
because it's their body, their life, in the quality of their life and the choices
Yeah.
they make. So it's a partnership.
Yeah,
But the patient always is driving the car.
Yeah, and this reflects back to how treat your patients, right? It's up to them. You always surround yourself around them, not they have to adapt to you. You have to adapt to them.
Yeah, there may be 2 or 3 options for treatment, even high-tech treatment. And if you have a relationship with a patient under those circumstances where they trust you and they trust you to make good recommendations to them, you can guide them to what you think is the best option. But at the bottom line, the patient and the family need to be on board and willing to go forward.
Yeah. Now, recently, this has happened. The COVID-19 pandemic. As a pulmonologist, this would have been probably one of the highlights of your career in terms of different circumstances, right? How did that experience impact your practice and your perspective on the field?
I've been through other things. I was practicing when AIDS hit.
Yeah.
So I saw that come and how it transpired. So this isn't, for a lot of us, it wasn't our real first rodeo with a new disease. What was different was the availability of information and even misinformation everywhere. Everybody had an opinion, everybody had an idea, everybody had read the most recent thing, and trying to wade through that to the truth or the best option was probably the unique thing about this new disease entity. In terms of my practice now, sadly, I think the biggest change that's come from COVID is that people have lost some of the trust in healthcare.
Yeah.
There's just a little bit of a lingering suspicion about what healthcare is doing nowadays based on what happened in the swirl of COVID.
Yeah.
And it's very real and very sad.
Yeah. Just to watch your own patients start not trusting your practice that you've worked all your life for, and especially in COVID-19 hit pulmonology really hard in terms of the scalability of it. It required basically all minds from all over the world to just lock down and focus on this.
Yeah, it was all hands on deck,
Yeah.
no question about it. And we got through it, and we got a lot of patients through it, particularly once we figured out, budesonide for pulmonary involvement. But again, just the overall events as they transpired, I think it's fundamentally changed for a lot of people, the doctor-patient relation, the healthcare-patient relationship, doctor-patient relationship.
Yeah, that is.
Your generation's going to have to work it back.
Yeah. The younger generation's gonna have to take it. It's like save it, right? Take it up a notch, but also focus on the trust of the patient more than the ability to figure out new diseases, like find more cures. That's important, but the real importance, who are you going to cure if nobody trusts your healthcare, right? So that's just a really important topic.
Okay, so we'll start back with our second half. Okay. So I heard a lot about undergraduate students who have told me, like, oh, you can do whichever major you want, and also do pre-med with that. And so I'm actually in a lot of business classes at my school as well, and I also have this sort of the dream to open my own practice one day, as I'm a doctor. So what are some key differences between owning a practice versus, as you said, you're working at Parkland at UT Southwestern? What are some differences between the practice and owning a practice and the business aspect of it, as well as working in a hospital?
The difference is the business aspect of it. As if you're an employee, you're not touched by anything related to your practice other than, here's your schedule. Yeah. And these are our expectations. In a practice, basically, I get to do what I want. Yeah. I come when I want, I leave when I want. If I want to see 20 patients a day, if I want to see 5 patients a day, I mean, the people that I work with are people I choose. So it's just a whole different, whole different thing. It really, private practice is getting harder and harder, and fewer people are doing it. And unfortunately, it's probably because some of the business aspects of it are just, you're in medical school, you're not trained in anything related to the business of medicine, and it can be overwhelming, or it just doesn't seem like it's worth it.
Right. Yeah, you mentioned, like you said, like challenges, especially in today's modern age with business. So when you were starting this practice, did you have any like logistical challenges or financial challenges that you had to deal with?
The logistical challenge then, as is now, is personnel.
Okay.
I'm just finding good people who interact with patients in the way that you want them to, or the way you would want to.
Right.
So HR.
Okay.
For me, the only negative to having a private practice is HR. It's a challenge to work with, discipline, or even fire someone when it's you and them on a daily basis.
Right. Makes sense. So what skills would you say that owning a practice has, instilled in you, like the time that you've worked here, versus some of the skills that you learned from working in a hospital, both like personality-wise, just knowing more about,
the business part of it, and just a real understanding of the business part of it, and because you get to decide your own retirement benefits.
Right.
You need to be up on all those options.
Yeah.
The other thing is that in a private practice, you're it. I mean, you're where the buck stops. If you're an employee or you're like on the faculty, there's always a non-medical person or someone who you can put things on. Like, oh, I'll talk to my manager, or gee, I'll have to see what that committee says, so that you can always be one off from the final pain of a decision or the final battle of a decision. Here, I don't do it, it doesn't happen.
Right. Yeah. So there's a middleman or middlewoman between the final decision.
And patients, a lot of patients sense that, is that if you call this office, you talk to someone who answers to me.
Right.
If you call a large entity, you talk to someone who answers to someone who answers to someone who then maybe answers to the doctor.
Right.
So that there's the immediacy of literally being one phone call away from me is a big difference for patients.
And backtracking on like the like trust that people have with healthcare, I think that may be another reason why people may prefer like these small time practice, at least for like less severe cases. I feel like forming that relationship with the doctor is nice to have.
Well, I tell you, if I was still on the faculty, or doctors that I know that are in large practices or private equity-owned practices, I think it becomes even more important that you have the ability to establish trust with the patient, so that they understand that yes, you are their doctor. You're not just doing it today because you were assigned to do it.
Right. So for doctors opening their own like practice in the future, such as I want to, and like you said, right? A lot of doctors don't really get the business side of things until they reach that point. So what would you say are some skills that they can develop early on to know more about and be prepared about?
I mean, a lot of physicians do go through business school or end up getting an MBA also.
Right.
I don't know if it's something you would ever actually get in a course or anything, but you need to be a good judge of people, and you need to know how to hire the right people.
Okay.
So that, my office manager's been with me for over 30 years.
Okay.
I can't imagine doing this without her, because she cares about her job as much as I care about mine.
Right.
We communicate well, and I rely on her for a lot of the business things, in a lot of the non-medical functions that I don't have time for or haven't made time for. So I would tell you, if I was going into private practice, most important thing I would learn or I would want to know is I would hire a great financial advisor, a very good accountant or lawyer to help me with business things. And I would say that would probably be true even if I had an MBA.
Right.
I mean, it's so technical and so complex, you need experts at it.
Right.
And then I would want to be able to hire a great office manager.
Right, yeah. Like you said, right, like doctors, they don't get much time. So having that backup with you is really crucial.
Yeah, I mean, if you can't be taught the expertise, you go find it.
Yeah, right. Makes sense. So how can young doctors sort of explore and, especially if they're either in residency or in medical school or even in pre-med, explore if, owning a practice or, just going along the path of residency and working in hospitals is the right choice for them?
That's actually a real challenge. That's a hot topic right now.
Okay.
I'm involved with the TMA, and that's one of the major pushes we have now. With the TMA is how are we going to have more new doctors go into private practice rather than employed? And it's really a daunting task because when you're in medical school, you're surrounded by people who are employed. And they don't have a perspective on what a private practice is like. So you don't have a role model, you don't have a mentor to realize the other way. So that unless you have someone in your family who's a doctor who's in private practice, or you shadowed someone and saw it another way, I think a lot of people really don't even consider it as an option,
Right.
just because they don't understand it.
Right.
And that's a real hard one to break down, especially as more and more physicians are employed. There are fewer and fewer private practice role models.
Right. Makes sense. So for medical, like you said, I think Milan discussed with you, right, like your whole inspiration on choosing pulmonology and your whole backstory and the cases that you had. For medical students, which medical specialty, who are unsure of like where they want to go, what if they want to go in the practice field, if they want to do hospital, if they want to choose a specific specialty over another one, what advice would you give them about finding their way?
I would tell you, keep an open mind. I know friends of our family have kids in medical school, and one of them has wanted to be a plastic surgeon forever.
Okay.
And sure enough, in her third year after her plastic surgery rotation, she now is going to be a resident in urology. So if you decide I want to be a pediatrician, fine, but keep an open mind to all the possibilities, because during your training, something will happen. You'll have an interaction with a mentor, a patient experience. Something will happen where it'll open like, gee, maybe I want to do something else. So that I'm sure a lot of people know from the get-go they want to be a surgeon. But in training, you want to be an orthopedic surgeon, you want to be a brain surgeon, you want to be a urologic surgeon. So you got to keep an open mind. If you get your blinders on and only focus on one thing, you might miss that moment where you realize you would be happier doing something somewhat different.
Right.
So I don't think there's any rush,
Yeah.
especially in the first couple of years of medical school, and for sure as an intern. There's a rush to pick what you're going to be in 10 years.
Yeah.
It'll happen.
Yeah. No, I have a lot of family friends who, always ask me like, oh, what do you want to do? What specialty do you want to go into? I'm like, I'm not sure right now.
Which is an honest
Yeah.
answer, because very few people really know, and the people who think they know, oftentimes, it turns out to be different.
Right. Yeah. So, what do you think for aspiring pulmonologists? What do you think would be something in the field that would surprise them? Surprise them in the sense that they may find interesting or even daunting for those who are incoming or even those who are thinking about it. What might be some advice that you give them about?
Probably the most daunting thing, and I don't think that's unique to pulmonary, is just the pace of progress and change, so that when you finish your training, you may be skilled with endobronchial ultrasound, but within a year or two, there'll be advances in that technique and additions in that technique that you're not trained to do. And you're going to have to constantly be on the prowl for how you're going to keep up. Where would you go to get that training or that experience to keep abreast of the progress that's being made?
Yeah.
So it's a real challenge to keep up.
Yeah. I actually had a nephrologist. I suffered from a kidney obstruction a couple of years ago. So I had a nephrologist. He was also at UT Southwestern, and he was telling me how like the situations and the technology from when he was in medical school, and he's a pretty young guy. He's like his 40s maybe. That the techniques that they've used to counter and cure the same thing I had maybe 10 years ago is much different than what they had to do for me.
No question. And that's true in every specialty. The pace of knowledge and the progress and advances is just stunning. It's absolutely stunning.
So
thank goodness for Google.
Yeah. So how do you go about in getting that training and education? What are some ways that you do that?
My personal way that I've been able to keep up is quite literally every day since I graduated from medical school, I spend 30 minutes reading literature. And a little bit at a time, but slowly but surely I'm able to keep up. So that for my personal thing, I just am constantly reading, when I say read, like if I get the annals, I'll read the abstracts. Not the entire article, unless the abstract gets my attention, and then I'll read it, or I'll pull it to read it later. So, and I think that would be a habit everybody needs to develop is, you're just gonna have to keep up. And yeah, it's easy to look up something on Google, but when you're sitting with a patient, you can't excuse me. I need to answer your question from Google. You got to have some sense of what's available and what's out there because patients come in and they're also able to read and see some of the new things. So they'll come in and ask you a question about something that is new. And we saw that in COVID. A lot of times things were moving so quick and things were so instantly available in the internet that a patient would come in and ask a question of something that had been on a website that morning that I hadn't even seen yet. And so, you just basically had to just keep constantly alert to it. And that's across everything in medicine.
So,
I tell you, if you quit trying to learn and keep up, you're going to get left behind.
Right, yeah. And I think that's true for, being in high school and even, college and stuff. Having that, inner curiosity just to learn more about whatever it is you're trying to do is always a good thing.
Well, yeah, it's not that you just need to learn it. It's frankly, in order to keep up, you have to. You just have to.
So in your, your medical journey throughout, having practice and working in at UT Southwestern, even throughout your early years of schooling, do you remember any specific patient stories that have truly inspired you and have sort of altered the course of of who you are today?
Oh yeah, absolutely. We talked about it.
Two of them.
When I was an intern at Parkland, we had a 19-year-old girl have her 5th heart attack. And my junior medical student drew her blood that morning and had an extra tube of blood and had it in his pocket. And during rounds, he was looking for something and found it and pulled it out and was holding it up. And the tube was half lipids. It was half cream and half blood. It had separated, just sitting in his pocket. Well, it turns out my attending at that time was Joe Goldstein, who won the Nobel Prize for lipid genetics. And he saw that tube of blood. He just stopped and he lit up and said, "Where'd you get that? Who is that?" And rounds stopped, and the whole group of us all went to that young girl's bedside for him to meet her. And it turns out that her family was the family who kind of broke the puzzle of the genetics of cholesterol that led to not only a Nobel Prize for them in Southwestern, but probably statin drugs. So, I've got lots of examples like that. Yeah.
That's really cool. Some patient, you may not know it, but they might lead to new discoveries, and everything's changing, right? The human
Yeah,
body.
but I've done this long enough that, patients in the ICU that desperately ill. I mean, I can remember one who, I still see her as a patient, who was pregnant with twins and had ARDS. And we were able to save her. And she went on and had normal healthy kids. And I still see her, and she shows me pictures of their college graduation. So it's really gratifying to know that you were part of something. The nurses, the respiratory therapists, the physical therapists, all of us kept this young woman alive, where she now has a family. I just wish everybody who helped take care of her could also see the pictures of the girls when they got married. Just how well they're doing. It's really gratifying.
Of course. And like you said, right, like all these stories, the human body is so vast and so complex, and it can change in a matter of minutes, hours, or even days. So, what are some valuable lessons that you've learned throughout your journey as a pulmonologist specifically, but your sort of course of medicine? It's allowed you to it's brought changes within you, but also changes within how you treat patients, how you talk to patients, and any specific instances where a patient has shown you or allowed you to change.
I can tell you, just in a really general sense, it comes back to the fact of the relationship you have and trust. And with the way it is now, patients do have the ability to come in with information that is spot on.
Right.
Whereas 15, 20 years, I was the only one who knew that. Now they come in and it becomes more of a conversation than an instruction. So that you just need to not only have patients trust that you care about them, but you need to be able to listen. It's always, I think every study that's ever looked at is if you, and this is something that I think it's a little bit lost now in the next generation of doctors, because the testing is so sophisticated, and the test oftentimes can give you the answer. But every study that's looked at it is if you allow a patient to talk and tell you what's wrong or what they think is wrong, 80-85% of the time they basically make their own diagnosis.
Right.
And your role is, because you're medically knowledgeable, to take their description of their illness and give it the name of the disease and the treatment that it allows. So you got to be able to listen and assimilate information.
So, looking back on your career, what would you tell your younger self on this journey? Maybe allow you to change, or even maybe go about things in a better way, or maybe not even change anything at all.
Well, that's a hard one.
It is.
Probably the hardest thing to learn, for me to learn, and I think this is true for most medical students, even if they won't admit it. I mean, if you get into medical school, you're obviously bright.
Right.
And you're probably a little bit type A. You have to learn the ability to say, I don't know. It's not a failing. You're not going to disappoint your patients. It doesn't mean you're stupid. It doesn't mean that you're not keeping up. It's a real challenge for people as they go through their training, where they're expected to be the best. They are the best. They're expected to know more than anybody else. To be confronted with a situation where you have to say, I don't know. But when you say I don't know to a patient, you also have to convey to them is, I don't know, but I promise you I'll find out. And we'll get the answer together. But that's a real challenge for people to learn how to say I don't know.
Yeah.
And and people get in trouble with it is they'll create an answer that turns out to be partially true.
Right.
I mean, you can imagine the sequences where if you're afraid to say I don't know, and you give them some answer, it turns out to be wrong. It happens all the time. And when you talk to patients and they're describing what other doctors may have told them about their illness, because I do a by referral consultation.
Right.
A lot of the things that they come up with, it's like, I wonder if the doctor really said that to them, or is that what they heard or thought they heard from the doctor, because it's so off base.
Yeah.
And yet I always wonder if the doctor was just not willing to concede to the patient, because I don't have an answer for that.
Yeah.
But here's what I think.
Yeah.
It turns out to be totally wrong.
Yeah.
So it's a real challenge, it's a hard thing to learn.
Yeah. I agree, especially in this like competitive sort of world, right, where everyone's just trying to be the first person, trying to be the best.
Well, that was, I was saying about being at Parkland as an intern in my training, it was so busy
Yeah.
that we all knew we were in the same situation. Everybody was used to having the answers,
Yeah.
and now you're in a group of 35 people and we're all looking for the answers at the same time, and it just leveled things completely. And you know, people that might have been your most fierce competitor in medical school became your best friend.
Yeah, of course. So if you could share one message, especially to our generation of high schoolers, specifically our age, for those who are approaching college applications next year, who are going into pre-med and have the dream to be a doctor, what is one piece of advice? We'll finish off with this. One piece of advice that you would give them?
Study hard, pass all the tests so you get into medical school and get a good internship and residency, but never give up who you are. Just because patients relate to you as a person and as a physician. If you only focus on becoming that physician and lose your sense of yourself or how you present yourself, you won't serve your patients as well as you probably should or could.
Right. Well, thank you so much, Dr. Chappell.
Okay. Sure. Certainly.
Thank you so much. And
Hard questions.
Yeah. Yeah.
Introspective questions.
Yeah. I think that it really helps us as individuals, but also people our age who are going into pre-med and who have the different stress factors of their life with college applications and finding internships, shadowing opportunities, this, that, whatever. So it's good to see and talk to somebody who's been through that process.
Mm-hmm.
Gain some insight for ourselves as well.
Yeah, you get to a point where if you get into medical school and then you get your internship, like I was saying, the momentum just carries you. It just pushes you along, and you just go with the flow. And if you perform your best, you'll come out of it as a good doctor.